Hi everyone, welcome. Yeah, we start the second lectures by Dr. Sarah Trinh soon. So I hope you have the good time to review the lecture last week, and now the second part also interesting, at least for common doctor, non-pediatricians like us. Sometimes we got asked about kids' question as well. At least we know something dangerous to tell them to go to the hospital instead of trying to be a hero and cause more harm than good. So that's the lecture for today. So Sarah, yeah, take it away.
Thank you, Edmund. Hi, everyone. Hope everyone have a nice week. All right, I'm going to share my slides. So hold on one second.
Good.
Excellent. All right. So today we'll talk about red flags. So as Edmund said, it's just kind of common concerning sign that a child is in potential danger and need to go to the hospital. All right, so let's do a quick review from the material we learned last week. So again, just this is an emphasis that like we are talking about a child with fever, right? So a very common symptom that you will see, and the way that I approach getting the history is using the mnemonic Mosdir. So do you guys remember what it is? Anyone can feel free to say out loud, unmute and say out loud what you guys remember what it stands for.
Yes, most D stand for M is method, O is onset, S is symptoms, T is treatment, D drinking, E eating, A I just forgot, and R is rich. I just forgot the A. Sorry.
No worry, you got most of it. So A is for activity. So whether or not a child is playful, active, and then yes, the last one is risk factor and red flag. So that is going to be the part we're focusing on for this lectures. Great job. All right. So what is red flags, right? It's, for definition, it's any kind of sign or symptoms that raise concerns for conditions or complications that will change your management plan, right? If you have a kid who's just have a fever and a common cold, you manage differently. If you have a kid that you worry about bacteremia or sepsis or meningitis, you will manage differently, right? So those symptoms that kind of point you one way or the other, we call them red flags. It usually symptoms that are associated with any kind of life-threatening conditions. The symptom that is helpful to guide you in where the patient should go, or we call that disposition. Disposition means like what's the status after the consultation between you and the patient, whether the patient is being admitted to the hospital or the patient is safe to go home. And then if you're in the ED, you have to decide whether or not a patient is just okay to go to a regular ward or they need an intensive care. And then whether or not immediate treatment is required, or you can watch and wait and see how things turns out, right? So those are also kind of helpful to kind of give you some idea of what you need to do. And again, these are very dependent on what the presenting symptom and the differential diagnosis that you are working with, right? A teenager with neck pain alone might be nothing. It might just be sleeping in a weird position overnight, and now they have like stiff neck. But a teenager with a fever, a headache, and a stiff neck is a very different story, right? So it's very much depending on what context those symptoms presented with that raise the concern. And usually these are times where the parent input is very important. And usually that is one part that we always ask as pediatricians to every parent right after the chief complaint is, what did what brought you in today? Why did you decide to seek care right now? Like the child could have been having fever for the past 3 days, but they didn't show up 3 days ago, they showed up now. So something must have changed that caused the parent to have concern and brought the kid to the hospital. So these are the kind of questions that we always ask. All right. So since we are talking about fever, I'm just gonna kind of list out a couple common red flags that you really need to know when you like assessing a child with fever. So any sign of dehydrations, any sign of respiratory distress or failure, any sign of impending cardiovascular collapse, any CNS or central nervous system involvement. Kawasaki disease is a very common and dangerous concern, especially in a child with fever that you need to rule out. And then any kind of like weird rashes that associate with life-threatening conditions. So we call them the deadly rashes. That's the thing that we usually screen for. All right, so we're gonna go through each of them in detail. All right, so dehydration, it's pretty straightforward, right? But a lot of time you might not be able to see the patient in person. So how do you assess those? You can get that through history by just asking simple questions like how have the kid been eating, if there is any symptom or problem that associated with increase in insensible loss, right? So if you have persistent vomiting, you have persistent diarrhea, you have any kind of burn, you have prolonged fever, all of those increase the water loss, and that will increase the risk of dehydrations. And then obviously if the child starts to have decreased output, that will be the concern. So the common questions that you can ask is, how has your kid been drinking? How's the appetite? So pretty similar to your triage questions, right? And then, so this is for younger kids, so like assessing the output, like how many wet diapers your kid have had today, when was the last time you have he or she had a wet diapers. Right, so next one is respiratory distress. This is usually very important in younger kids, especially like infants and toddler who can just pick up a common cold, but can progress to have severe symptom with the common cold, need to be admitted, such as bronchiolitis, right? So these are the one that you kind of need to look out for. So for younger children, the sign of respiratory distress or impending failure is tachypnea. So breathing very fast, grunting, retractions. For those who's not familiar with the word, it's just pulling to breathe or showing ribs. So they kind of like using all of the accessory muscle to breathe, right? They sucking their chest in to breathe every time. Nasal flaring, head bobbing, barely breathing. And the reason why I emphasize these is because, yes, this is physical example, but it's also helpful if you can describe that to the parent, and the parent can actually tell you, like, I have had a couple of times I was like, let count the breathing with me so that I know how fast your child is breathing, right? So I would say, start counting, and then she would start counting, and then I will just, like, based on her counting, have a rough idea of how fast the child is breathing. And then sometimes you can just ask them to check a video of their kid, and that you can kind of have a quick look of like how the kid is breathing as well. And again, on the right side is a couple of sample questions that you can use to ask, to try to assess for these symptoms. But again, physical exam is crucial. So if you have any kind of doubt that the kid might have increased work of breathing, that kid need to be seen, okay? Because a physician need to actually lay hand on the kid to assess for these. All right. And for those who...
When is my allergies bringing me to 10?
You need Astapro.
Astapro?
It's faster, bro. 8 times faster.
All right. See if I can skip forward.
Compensatory mechanisms is limited for some primary lung problem,
so
like
that is what it looked like to have
will...
retractions. Show back a little.
Now there's...
All right. So you see when they breathe, they just kind of suck in instead of kind of expand. So that
comfortable tachypnea, which
is the retraction right there.
When...
So that is a couple sides of increased work of breathing. And then this is the link to the YouTube video for anyone who want to watch the entirety of that.
An infant.
All right. So for older children, their presentation might be a little bit different. So they're still going to have tachypnea, but usually they can describe how they feel to you, right? It's not just the what you can see. And their chest voice differ, so they usually don't have the typical retractions that a younger child would have. So they usually describe that as chest tightness, short of breath, chest pain. You can sometimes hear them just like they're unable to speak in full sentences, and then they can have wheezing or stridor. So wheezing are a sign of small airway collapse, and then stridor is the sign of there is risk for upper airway obstructions or compromise. All right, and this is the couple of sample questions you can ask. All right, so the next concerning sign is any kind of shock, right? Impending cardiovascular collapse. So they usually look very pale, they have cold hands and feet, the skin become very mottled. They can be very sweaty. And it's a very common sign of common presentations in a neonate with heart failure is they sweat every time they feed. That is a very typical sign that you will see for a child with heart failure, for neonate with heart failure. And then if it's really bad, they started to have long-term mental status, right? All right. And then the next organ we worry about is the brain, right? The central nervous system. So you will assess their alertness. Any change in alertness can signify a potential brain involvement, and that usually need to be assessed or need to be seen by physicians. And kind of alter sensation, so numbness or tingling, especially associated with fever, is very concerning because it can signaling an inflammation of the spinal cord or the brain, so that need to be seen right away. Loss of functions, weakness, abnormal movement, concern for seizures, anything like that really need to be seen, okay? All right, Kawasaki disease is another one that we always screen for in children who have prolonged fever. The definition is any child that have fever for more than 5 days. It is an immune-mediated systemic inflammations. And the complication that we really worry about is that it can cause the dilatations and aneurysm of the coronary artery, and those can lead to myocardial infarctions and can actually lead to cardiogenic shock. That's why we worry. And the mnemonic we learned for Kawasaki disease in the US is crash and burn. So crash stands for C for conjunctivitis. So they have to have bilateral conjunctivitis or pink eye. They have a very polymorphic rash. Polymorphic means it can look like anything. Adenoma, so swollen lymph node, especially cervical lymph node. Strawberry tongue, so their tongue look very beefy, very red. They have like kind of pit, just look like a strawberry. And then hand and feet, redness and swelling. So those are stand for crash, and burn is just a reminder that you need to have fever for 5 consecutive days. And this is what it looked like. So yeah, again, any child that have prolonged fever, you need to make sure that you screen for Kawasaki because that is something that need to immediate treatment and have long-term complications if you don't recognize and treat them in time. Right, and then the last one is just about rashes. I'm gonna go very quickly through these rashes because they thankfully are fairly rare, but it's cannot miss. All right, if you have a patient that have this rash, you need to be able to recognize because you need to intervene right away, otherwise they will die. So Steven Johnson and toxic epidermal necrolysis. So these are usually drug reactions. Intense redness usually involve the mucosal, and it usually associated with antibiotics and anti-epileptics. So the question is, was it just it's taking any new medication when the rash occur? That is very important, just to give that temporal relationship between the rash and the introductions of a new medication. Necrotizing fasciitis, or the common layman term is flesh-eating disease. So you just need to get a history of whether or not there was any kind of cut or injury to the area prior to the rash happens. All right. And then this one is very common. Well, not very common, but more common than the other rash is the meningococcemia, especially in the population that is under-immunized. In the rural area in Vietnam, you might see these a lot. So it's caused by Neisseria meningitidis bacteremia. It progressed rapidly and very deadly. So you need to be able to see them. Usually by the time you start seeing these rash, this patient's gonna go into shock very soon after. So you need to be able to recognize them. And then the last one is toxic shock syndrome. Sorry, there's a typo right there. So usually associated with staph infections, and the textbook case is retained tampon, like a teen who was using tampon and didn't change them frequent enough can pick up these staph infection and can lead to toxic shock. All right, so this is what the purpura rash that is typical for meningococcemia. So these are non-blanching. So if you press on the rash and you release, the redness doesn't go away. It stays the same because it's the vasculitis. So those are very, very concerning. All right, so the typical questions that you can ask is right there. All right. So red flags is not just helpful for you to discuss and then to gather the history. It's also very helpful as an anticipatory guidance for parents, right? So even though the kid looks fine right now, you're seeing the kid looks fine. If you can teach the parents that these are the couple of signs that can signify something is going wrong, you need to bring the kid back. So it's also very important to kind of discuss what a couple potential red flags that they want them to come back for. So the counseling, so explain why you're concerned about the red flags, and then explain to the parents what they need to look out for, right? So the framework that I usually use is, let's say you have a kid that have a teenager that have fever, headache, and a stiff neck, and you know that you're gonna need to admit this kid to the hospital, do the LP, rule out meningitis. You have to explain to the parents why, right? Because they can just say, oh, they probably just have a flu. Why are you doing all of these tests? So the way that I approach those kind of situation is, I would say, I am concerned that the symptom, especially with the stiff neck, is potentially meningitis, which means the inflammations of the membrane around the brain, and that is very dangerous and need to be treated right away. And therefore, I'm recommending to proceed with this procedure and admission. All right, so that is how you gotta explain to the parents why you're concerned about those symptoms. Or on the other hand, you have the same case, but the kid didn't have any red flag at the moment, but you can counseling them like, right now, I think it's just a viral infection, but if you develop like stiff neck or blurry visions or a rash that like spreading in your lower extremity, please return to the emergency room right away, because that could be symptoms of meningitis, etc. Right. So that is kind of what red flag is used commonly in clinical practice. Right. So kind of putting things together a little bit. So you've been learning throughout the course about each separate part of the history, but this is what a comprehensive pediatric history will look like. So we're always going to have the chief complaint, which is why the patient is here. The second one is the history of present illness, which is or short form is HPI. So it's just what happened in the past few days. It just the most related, the history that related to the current chief complaint and why the patient seek care today. And then trying to dig a little bit deeper through the history, depending on what the presenting symptom is. And then the quick review of system kind of based on, again, based on the presenting symptom, just trying to fill in the blank, and then especially to screen for those red flags that we was talking about. All right, and that's all I got. So it's a very short and straightforward topic. But it's not just for pediatric, right? Every specialty have conditions that have red flags that you need to counsel patients about. So I would challenge you today, it's just for pediatric, because today is my day and everything you're allowed to talk about is pediatric. But for homework, just think about what other, like what common condition that you deal with and what would be the red flag for those like common conditions and how you would counseling your patients to recognize them and to come to you when those actually happened. All right. And that's all I got. All right, any questions, concern, thoughts? I still have 7 minutes. I'm gonna tease you guys a little bit. Okay. Anyone want to chat about like the potential red flag in your specialty?
I think in children it's really hard to concern with their parent about all these red flags, and when I end up conversation with their parent, I often say that if something doesn't seem right and you worry, so I think you need to bring her or his rider in, and it's a way better to be safe. And I said that trust your instinct and don't hesitate to reach out for help. Yes, because a parent can remember all these red flags as one time. So I think when we end up the concerning with the parents, we need to say something like that. Well, what do you think about that?
Yep. So I think that is a very good place to start. The challenges that sometimes you will face is that sometimes there will be parents who don't know what they don't know, right? You are the specialist who have an idea of what you are worried about. The parents do not have those knowledge in their mind, right? They might never heard of meningitis. They might never heard of all of the like Kawasaki disease, all of those things, right? So you are the expert that you have to kind of give them somewhere to start. And again, that's why I said red flags is very dependent on what your working diagnosis is. I'm not giving them every extensive list of red flags because that will take the whole textbook, right? I cannot teach them those. But when you see the patient for the first time or you get a history for the first time, you have a rough idea of what your concern is, right? You have a 2-month-old with running nose and a slight fever. It could just be a cold, right? It can be a cold progressing into a bronchiolitis, or it could be bacteremia, right? So you have that working diagnosis, and your red flag counseling will be focusing around those, right? So it will focusing more on respiratory distress sign, right? If your kid is breathing faster, if they seem like they're struggling to breathe, please bring them back. If they're refusing to eat, if they do not make wet diaper, please bring them back, right? So those are the kind of depending on what your concern is at that point, what is your differential diagnosis, the red flag will follow. Like I will not talk about own mental status or any other things with them I would just focusing on the kind of the 3 or 4 most top differential diagnosis that I am really concerned about and kind of focusing on those. Does that make sense?
I think even though you depend on your chief complaint and your diagnose, but sometimes we can mix some important red flags, and it's better to say them if you feel right, if you doesn't seem right, and anything you make you worry, you need to you should bring her to the emergency room or doctor clinic. I think that
yeah, I think that that's totally legit, right? And it's only going to be the last part to say, right? So usually I would say if you have concern, if you see these symptoms or if you have any other concern, please bring them back, right? So that is always going to be a given. Anytime you have concern, bring your kid to see a doctor, right? That's why we say always just your instinct. But again, you have to give them some pointer to look for, right? They can have, this can be their only child, or they can have 5 other kids and work full time and have other things in life that they need to worry about, right? So if you don't give them something to look out for, it's very hard for them to stay and kind of watch their kid 24/7, right? And then especially like for something like Kawasaki, a lot of those symptoms are very benign on its own, but when all of them happen together, that become an issue. Like a pink eye is very normal. In the US, pink eye are very common. A lot of times they don't even bring their kid to the hospital for pink eye. Same for having a lymph node. Some parents will bring the kids to the ED, some won't. But you kind of, if you have concern, you kind of have to give them some pointer that I don't think it's going to be an issue, but if you see one of these, please call your doctor or bring the kid back, right? So that just an additional education point for them. Does that make sense?
Okay, thank you.
Terrific. Let me share my screen and get you into the breakout rooms. Okay, so everyone remembers how to get into the breakout room. And then these are the rooms.